to Radiologists, a podcast by University Medical Imaging Toronto, where we discuss the most interesting topics through the lens of Canada's largest medical imaging department. I'm your host, Satish Krishna. It's challenging enough to look into patients to see what their liver looks like or their kidney looks like, but it's a whole different challenge trying to look at what the liver or kidney of a fetus looks like when it is inside another human, inside the uterus. And to speak more about these challenges, we have the king of antenatal imaging, Dr. Dilkash Kajal. Dilkash, it's a pleasure to have you here.
Satish, thank you so much.
So Dilkash, what does prenatal imaging involve? What is the spectrum? What do you do?
So basically, prenatal imaging is looking at the pregnant patients, right? So right, even before they start pregnancy, sometimes they have to get IVF, fertilization cycles, so right? And once they are pregnant, then looking at the gestational sac, make sure everything is developing fine. And once everything is fine, then we have two important milestones that we always try to look at. One is early 11 to 13 week scan, which is called the nuchal translucency scan, where we look at this fluid at the back of the neck. And then the most important next milestone is the anatomy ultrasound, which is done typically at around 18 to 20 weeks, where we want to make sure that there are no anomalies, the baby is structurally fine and growing fine. Right after that, you can look at the biophysical profiles, the placental studies, make sure that the ongoing third trimester growth is fine. So this is basically the prenatal imaging.
Wow, so it starts before pregnancy and almost up to delivery, and maybe sometimes placenta and a little bit after that as well. So in a way, this continuum is interesting because it starts where women's imaging ends, or there is probably an overlap with women's imaging on one side. And on the other side, there is this overlap with pediatric imaging. And that's how the circle is kind of complete.
Exactly.
But how did you decide to pursue prenatal imaging in your career? How did this happen?
Interesting. So that dates back to quite a few years. So I was a radiologist back home in India, and that was 94, 96 when I did my residency. And after I passed my residency, and then I was a practicing radiologist. And so I owned an ultrasound clinic because that is what I could afford. I couldn't afford a CT or MRI. So I started doing the ultrasounds. And then in the ultrasounds, the fetal imaging somehow excited me. I really liked to see the babies. And at that time in my city, the prenatal imaging, it wasn't that developed. And so I looked into it. And I realized that there are level 2 scans, level 3 scans. No one knew at that time in my city that what is a level 2 scan. So I actually introduced that. And this is how it started. And then I came here, and so they knew that I had a lot of experience in prenatal imaging, and that's how I am here.
And a large volume of cases as well, because back in India, there's no limit to the volume of cases which we see there.
Not only that, Satish, so we don't have the technologists there, so we scan ourselves.
Yeah, absolutely,
right?
yes.
So on a typical day, I would scan maybe 60 patients a day myself, right? And my week was like 6.5 days a week.
Wow, okay. So you're scanning them yourself. And that's just great because it's just completely hands-on. You know exactly what you're doing here.
Exactly.
So now that you're here and you're taking care of all these antenatal patients, how does one become a prenatal radiologist? Is there like a structured pathway to becoming a specialist in this field here?
Interesting question, Satish. There is actually not so much of a structure in getting into prenatal imaging. It is a little challenging. So during your residency, you get 3 months of obstetrical ultrasound. Out of that, you spend a month in scanning and then maybe 2 months in reporting. But that is not enough to make you competent. It's enough to give you the basics, but you need to have more competence. And then you have the option of doing a women's imaging fellowship. So women's imaging fellowship is typically 50%, like 6 months in abdominal imaging and then 6 months in mainly in the breast ultrasound. And usually they get a month in OB ultrasound. And again, that is not enough. So if you want to be in a prenatal imaging and want to be successful and competent, it's better that you spend some time in a prenatal, well-established prenatal center. So maybe some people, they out of their fellowship, so you have 1 month of elective, so they use that month of elective into OB ultrasound. And then continuously you keep learning and you have your mentors and they teach you. So that is how it will.
Interesting. So it looks like the pathway to becoming a prenatal radiologist is a little bit informal, in which there are no clear structured fellowships, but you really need to be interested. And it does make sense in a bit, because it may be not for everybody, because you need to appreciate the challenges and you need to welcome those challenges, because as I can imagine, it can be a really, really challenging thing. So what are the challenges which you face as a prenatal radiologist? Because you do adult radiology as well. Are there any fundamental differences, and what are the challenges that you face?
So the main challenges which differentiate prenatal imaging from adult imaging is when you encounter the abnormality, because that is devastating to the mother. And that is my biggest challenge, how to break the news right, in a prenatal imaging. And then obviously, how confident are you? What extra studies, what other additional studies you need to do. So those are the kind of challenges. So you have how to prove the diagnosis, because we don't have those biopsies that we can employ in the adults, right?
Yes.
So it's all prenatal testing, mostly non-invasive, just a little bit of invasive in chorionic villus sampling or amniocensus. That's the most invasion that we do.
Okay. And what are the modalities which you primarily use?
So the ultrasound is the modality just because it is non-radiation based. And also it is less expensive and more commonly used. And also we have wealth of experience because we have been using ultrasounds for decades and decades, right? But besides ultrasound, MR, again, it's not non-radiation based. So MR, but it's time consuming, it's expensive, availability is an issue, the magnet time is an issue, but it does help us a lot. So those are the main two modalities.
So with respect to ultrasound, it does make a bit of sense, because as you point out, it's just easily available and you can do it real time. But with MRI, one of the things which at least I know from adult imaging, even imaging the liver, is that sometimes the images are really, really bad because the patient is just breathing. Even that minor motion causes really bad images. And isn't that a challenge in fetal imaging? Because in adults, you can ask the patient, hey, stop breathing. How do you ask a kid to stop moving inside the abdomen? And how do you schedule it? And how do you get the best images possible?
Very interesting. So, no, we can't do that. We can't ask, even for moms, holding their breath might be difficult because when you're pregnant, you may not have all those breathing, holding tendencies. So that was the reason why MR got introduced later than ultrasound in prenatal imaging, because our sequences, as you know, very well know, that sequences are longer. So it was not possible. But with the technology advent and all that advancement, so we were able to develop super short sequences, which were like 1 second, 2 seconds, right? So with those sequences, we are able to do it. And we usually like to time them with the maternal breathing. Right, so just when the breathing is not there,
at least eliminate.
Just Yes.
At least eliminate one source of motion.
One source of motion.
Yeah.
Well, there are always challenging. The babies like to move, especially if there is a lot of fluid around. Early gestational, that is why we don't like to do MRI early on. We usually prefer to do it after 22 weeks when the fluid is not that much and the baby is a little bigger and less mobile.
Okay. So it's a matter of finding the right time to kind of do that so that you get the best information possible.
Right.
And I can understand how challenging this can be because ultrasound, even as a modality, the deeper the structures are, it becomes difficult to see. The smaller the structures are, it gets difficult to see. But in addition to that, you have all this motion, and then the patient can't hold their breath. And it's all compounded in MRI. It's just many times more difficult. And I really don't know how you do it. And we're really happy that we have experts like you doing what you do. And in terms of the challenges, you're talking about breaking difficult news to the patients. How do you kind of help patients with this? And is there a psychological toll on you when you kind of do this? Because in adult imaging, more often than not, we aren't discussing details with the patients too often. We just refer them to the clinician to kind of follow up, and patients are quite reasonable. Whereas here, I can understand that the mother's going to be really concerned, and like even you staring at the screen 2 seconds longer, they pick up on it and they're like really, really worried about it. How do you deal with that, and how do you deal with the toll it has on you?
It is challenging. And as you said, the mothers, they are excited. The partners are mostly in the room, so they are all happy. And sometimes they're planning a party, a gender disclosure party and all that, right? And with all this, and then you are walking into the room and you have something bad to share with them. It is very challenging and difficult for not only the patient, but also for us. But I think in the end, you have to do what you have to do, right? It's your responsibility, your duty towards your patient, right? So we do it in relatively in cordial circumstances, like to move them into a consult room, ideally with the patient and the partner if they prefer to have. And then we tell them, okay, this is what it is. And mostly when we have looked at some abnormalities, sometimes you're not even sure, or you might have to do further testing. So we tell them, okay, this is what we think it is, but it will need further testing. And also you need to give support to the patient, right?
Yep.
And you have to arrange multidisciplinary care, right? Because they might need to see the obstetricians, pediatricians, surgeons, or get more imaging. So you provide all that kind of information and support.
Does it involve only diagnostic imaging, or is there like an interventional component to prenatal imaging care as a whole as well?
So there is an interventional component, and mostly our obstetric colleagues are doing it. Some interventional radiology is sometimes, rarely we perform as well for the interventional part, but mostly it is the obstetrics component. The main intervention that they are doing is like in a spinal bifida or spinal dysraphism where the spine is open. So they can actually either go through open surgery, like cut the uterus and repair, or they can insert a fetoscope and repair it with fetoscopically.
Wow, okay.
And then other very important intervention that we have been doing here is the called feto. So for the diaphragmatic hernia, when the lung volumes are really small, then they put a balloon in the baby's trachea so that the excretions cannot go out and lungs expand.
Wow, okay.
So yes.
And all of this intervention is done with the fetus in the uterus, and
Fetus in the uterus.
that's amazing that how imaging comes so far along. Because if you remember one of the earliest days of imaging in which first ultrasounds and CTs came, it was just like a haze in which we are able to see something. But it's just so far along that we're not only able to look at the fetus, we're able to diagnose diseases, and able to do interventions to treat the babies when they're in the uterus. And that's just amazing. And in addition to that, the other aspect I wanted to ask you is there a component, as you point out, like the gender reveal, people are excited about that. Um, do you think that there's a role of like routine 3D imaging just to give pictures to the kids and stuff like that? I know that it's just become a big enterprise in the US. What are your thoughts on that?
To be honest, 3D ultrasound is a good modality. Okay. But my mentors always used to say, when 3D was just being introduced, they used to say, if you're not good in 2D, you cannot do anything with 3D. So the ultrasound, basic ultrasound is 2D. You have to diagnose each and everything on 2D ultrasound. If you miss it, how are you going to see it on 3D ultrasound? So 3D ultrasound, it looks good. It's a nice image, right? The patients, they get excited. It's sometimes easier for us to tell them, okay, this is how it looks. For example, if there is a cleft lip or palate, it's very easy to show on a 3D ultrasound, facial abnormalities, right? But 2D, it can never replace 2D ultrasound.
Okay. So 3D is good for patient education rather than making primary diagnosis themselves. And primary diagnosis is always made on 2D.
Yeah.
What other newer modalities and techniques are coming down the line? And where do you think that the field's going to go?
So in prenatal imaging, actually, Satish, there is hardly anything newer coming. So the only new thing is the more advancement in what we already have. As I said, the ultrasounds are much better technological advancements in the machine itself. Image quality has improved significantly, right? So 3D, 4D ultrasound. In terms of the MR, the super fast, the ultra fast sequences, the quality. So from 1.5 Tesla, we are now moving towards 3 Tesla magnet, so slightly more resolution. In terms of the advancement in prenatal imaging, that is pretty much it. But we are actually introducing something for the autopsy. So that is also an important component. So autopsy is basically when you are not very sure what exactly was the abnormality, or you want to have a full understanding of the genetic abnormality to make sure that it doesn't happen. For example, the single gene or multiple gene disorders that can happen into subsequent pregnancies. So you want to diagnose it, right? But usually for the autopsy, patient consent is low because autopsy is daunting. It also delays the funeral, and they are concerned that the baby will be mutilated and all that. So
there's a significant emotional component attached to that.
Significant emotional component, some cultural, religious component as well. So for that, we have actually a micro CT.
Okay.
And an MRI as well. So micro CT, so instead of the autopsy, we can look at the micro CT. For example, baby has skeletal issues, so we can look on the CT as well, right? And also we are going to introduce here at Sinai as well the MRI. So after rather than doing the autopsy, we're going to do an MRI so that we can have a better assessment and better look of what was wrong.
Oh, that's amazing. That's a very respectful way of looking into the baby. Even though we were not able to save this baby, we might potentially be able to save the next one or find ways to give the patient the optimal outcome eventually. That's amazing. But one thing I didn't really kind of consider earlier is that in adult imaging, pretty much for all kinds of imaging, if you do a non-contrast, we know that that's not enough. So be it a CT or an MRI, it's always done with contrast. Even ultrasound is done with contrast these days. In prenatal imaging, is there any role for contrast at all in any of the modalities?
Not really, because we are not very sure about the safety of the contrast, even though the studies have proven that the contrast is not that harmful as we thought. Even the CT as well as the MR, the gadolinium, even though it does stay in the amniotic fluid for a longer duration, it is always risk versus benefit. So whenever you want to make sure that what are we getting out of, what information, is it really that beneficial? If yes, then I don't remember that I have to use contrast in prenatal imaging so far. Only in circumstances, for example, there is an invasive placenta or cesarean scar pregnancy.
Okay.
And we are going to terminate, we are going to surgically remove the pregnancy. But then they want to have a good lay of the land, how the vessels are, where the vessels are. In those cases, I do a contrast MRI to give the surgeons all the roadmap.
So yeah, that lack of contrast can make it challenging. But I do get your point. One is that contrast may not cross the placental barrier, and if it does, now we need to be really, really careful that it does not affect the baby in any way, shape, or form, not just immediately, but down the line, because we might not know the long-term consequences of a lot of it. Because there was recently some reports, even in the adults, of gadolinium deposition. So we don't really know the long-term effects of a lot of these things. And finally, even if there aren't any risks, as you point out, there may not be much benefit beyond that. So yeah, I understand that it's just very, very tricky balancing risk benefits, especially when there's a lot of emotion attached in this. But does your specialty also involve early neonatal care as well? Because I understand that you can address some of these abnormalities in utero, but maybe there are some abnormalities which you kind of point out which need to be dealt with later, either in the baby or in the mother. Like in the mother, maybe in terms of invasive placenta, and the baby maybe some hydronephrosis or some urethral valve or something like that. Is there some continuity of care between the prenatal, antenatal, and the postnatal?
Yes, that's a very good question, Satish. So we do have continuity of care at Mount Sinai. So all the babies that are delivered at Sinai, if they have some issues, medical conditions, and they are like preterms, they get admitted to our NICU. And then we, OB ultrasound, OB radiologists, they also look at the NICU ultrasound. So we look at the head ultrasounds, we look at the
head ultrasounds. So you do ultrasounds of the heads of the
baby brain.
Wow, okay.
Right. So most of the time, because of the prematurity, they are prone to hemorrhages. So we have a protocol to look at the head ultrasound day 3, day 7, like that, right? So we want to make sure that there is no significant hemorrhage or there is no ventriculomegaly that needs a shunting or other support measures. And then we also look at the abdomens. For example, the neonatals, they have something called necrotizing enterocolitis, which they are prone to, or they are prone to volvulus. And as you pointed out, the renal conditions, hydronephrosis and all that. So we look at all those cases and all those conditions, and that is our continuity of care.
That's amazing. And I think that once beyond that time point, when they move into pediatrics, we have one of the best pediatric hospitals right across the road in sick kids, so they can kind of be referred there.
Exactly.
In terms of what you are doing, and I know that there are a lot of people who do ultrasounds, including the obstetricians. They do a lot of their own ultrasounds as well these days. But I'm still assuming that MRI is primarily a forte of radiologists still, which kind of really means that imaging should be under the domain of radiologists, because then there can be fragmentation of care when they're doing ultrasounds and we're doing MRI. And I understand that you do both and you take care of it in a comprehensive manner. Are there a lot of people like you in Canada? And is there a need for a lot more people like this in Canada?
It is a tricky question and a political question as well. So there is always a turf battle, right? University of Toronto is one of the very few centers in Canada where radiologists do the prenatal imaging. And mostly in academic centers, we have lost this ground to the obstetricians. Mainly it is the community where still the radiologists in community practice, they are reporting the OB ultrasounds. But here we are lucky that we are actually do this in collaboration with the OB group. So our COU, the Center of Excellence in OB Ultrasound, so we sit beside each other every day. Every single day we are there, collaborate with each other and report.
I think as long as you demonstrate the added value which radiology can provide, then you become indispensable in the context of the medical team. And that might be the reason in many other places, because quite often we operate in silos. We operate in our own domain and obstetricians in their own domain, especially when you're talking about a community radiologist in which they really aren't as specialized as you. They wouldn't really know the nuances of a lot of stuff or how things are managed. And maybe that detail is not just adequate for the clinician for the overall care of the patients. So, where do you see the future? Do you think that including MRI, it will slowly be taken up by the obstetricians, or do you think that when MRI gets better and we are able to make more diagnosis on MRI and interventions become much more nuanced, in which more diseases can be treated in utero, then the rise of MRI as well as AI and everything else coming down the line will shift the popularity towards the radiology side of it, and it'll just be like the prodigal son, which just kind of comes back into our fold again. Where do you think it's going?
So I think we are not going to replace ultrasound. So ultrasound is going to stay. It's such a powerful tool in our hands. So MR is never going to replace ultrasound. And also the cost and the magnet time is the biggest challenge that we all have. The scan time as well. So usually it takes 45 minutes to an hour, whereas ultrasound you can finish in 30 minutes. It depends on what kind of ultrasound that you are doing. And also ultrasound you can do as many times as you want. You can follow up every 2 days, every 3 days, right? MR is one stop. Then maybe in 3 months, maybe another MR, if possible at all, right? So I don't see that, but I think the role of radiologist is going to stay there. We add so much value, and just as we have so much support from the OB, and they also find support from us as well. We consult with each other almost on a daily basis. We have invasive placenta population. Almost our 50% of patients have invasive placenta, which get referred to us from across the province. And MR does add value so much that every invasive placenta case that comes to this clinic will have an MRI.
Okay.
Yeah.
So I understand that it's also due to distribution of resources, because the scan time in MRI is 1 hour, ultrasound is 30 minutes, but you can have like 13 ultrasound scanners. But MRI, that's just only one scanner, and only one day you get like certain number of hours. And I think it's mainly a resource issue.
It is.
In addition to ultrasound being real time and being much better.
Right. And the cost as well.
And the cost, which it kind of goes without saying. Ultimately, a lot of things boil down to that. What do you think is the attitude of trainees currently? Do you think that more trainees want to do it? And if not, how do you encourage them to, or how do you show them how remarkably interesting the specialty is? How challenging and rewarding it is at the same time? How do you kind of encourage the trainees to have more interest in this?
I think it is self-explanatory. Once they see the beautiful world, there is never a dull moment in OB ultrasound. We always have challenges, and then challenges is what motivates us, right? But challenge is what you will become a good person, a good professional. I'm reminded of a very short story. So there is a cocoon, and the cocoon was trying to get out of its shell, right? And someone tried to help the cocoon, thinking that they're having so much labor there. So they just cut open the cocoon. And lo and behold, the butterfly, it could never fly because it needs challenge to have the strength to its wings. Right? So this is what you need. You need challenge for your journey.
And what other advice would you have for any trainee interested in this particular field? Any resident or fellow? What kind of people should take on this? And what advice do you have for them?
I don't think that there is any kind of people who should take any person, any radiologist who is interested. It's basically what your heart tells you, right? If your heart goes into there, so let's go for it. I think many people are afraid of this field because of the lawsuits, because it's a complex situation.
Yep.
Malpractice and all that situation. I think that is one major factor. It's more so in the US and other countries rather than Canada. So we are still protected. We don't have that much of malpractice lawsuits. But I think that is one reason on the back of the mind. But I still think that it is what it is. So if you, this is your call, this is what your heart beckons you, you should go for it. And there are resources available. We are always there, right? So we had so many mentors in our life, and I still have so many mentors, and we are here to mentor anyone who is interested.
That's amazing. And do you have like an observership or something under you if people are interested?
Of course, there are people who does come to us from all over the Canada and even the rest of the world.
Yeah, so for those of you who are interested, the door to Dr. Dilkash's office is always open if you're interested in doing an observership, so please reach out. Ladies and gentlemen, that was Dr. Dilkash Kajal, King of Prenatal Imaging, and me, your host, Satish Krishna. See you in the next one. You were listening to Radiologists, a podcast by University Medical Imaging Toronto, the largest medical imaging group in Canada. Produced by Ina Levchuk. Learn more about us at universitymedicalimagingtoronto.ca and follow us on social media at Imaging Toronto. You were listening to Radiologists, a podcast by University Medical Imaging Toronto, the largest medical imaging group in Canada. Produced by Ina Levchuk. Learn more about us at universitymedicalimagingtoronto.ca and follow us on social media at Imaging Toronto.